Sure, the next presentation is going to be equally enlightening by none other than Professor ATUL Kumar, ex-chief of RP Center of Ophthalmic Sciences, AIMS. So, sir is going to talk about very interesting topic about disorganization of inner retinal layer, DRIL. So, what, when you see DRIL in macular edema, so is it going to change your approach to management? Because earlier we were talking about identifying these entities, but now that we recognize them, do we change our management? Over to you, sir.
Thank you, Professor Vishali. I'm much honored and feel thankful for having been part of your very honored course, and it's a pleasure to be speaking to all of you here, people who've come all the way from various parts of India to attend this meeting. And these courses are very academic, and I hope you understand what I mean. If you have a course conducted by Professor Vishali, it has to be very academic. So I'm going to talk about this biomarker, which is very important, and it's been identified in the last few years. And diabetic retinopathy or diabetic macular edema, they have biomarkers now, various biomarkers. So DRIL is one of the very important biomarkers, and you must understand these biomarkers when you treat diabetic macular edema or any kind of diabetic retinopathy, or you look at the picture. So you study the morphology, don't just see the vision, because study the morphology, see the inner layers, the outer layers, the ellipsoid band, all that has to be seen in its totality, and do it yourself. Check the scan yourself. If you don't check the scan yourself, or go to the imaging room and sit there and see the scan, sometimes when you see it live on the screen before the printout, or before it's sent to you, the image is sent to you probably, it's very best to see it. If you have the access to the screen in your own office, it's fine. But this particular biomarker was first described by Sun, and this was as late as just 6-7 years back. But that was the initial time when things started getting picked up more in diabetic macular edema and diabetic retinopathy, the OCT features. So it was basically the inability to distinguish the inner retinal layers, the ganglion cell inner plexiform layer, the inner nuclear and the inner outer plexiform. The inner plexiform, outer plexiform, inner nuclear layer and the ganglion cell layer were indistinguishable, as opposed to the outer bands, which are also very important. So the entire retina is very important. The vitreoretinal interface is very important in diabetic retinopathy. Each part of the OCT is very important. So it may take you a few minutes, or maybe a minute or two if you're very experienced, but otherwise spend time on seeing the image. And that's the proper imaging. You'll kind of get a thrill, an understanding which is much beyond of what just rapid go through a gross look at the images. So that's what my first thing would be to all of you. So DRIL basically is in the central 1000 microns, the central subfield thickness. If you see the grid shows the central 1 millimeter zone, which is in the central, which is also called the central subfield thickness. That's 1000 microns. So if 500 microns of that 1000 microns in width is involved, it's called DRIL. That means your inability to distinguish the inner segments. Now this is a marker which is basically suggesting impending or already setting in neuroretinal degeneration. It's not just cystic fluid or something which is going to be treated by anti-VEGFs. So it has a bigger challenge in the treatment. So anti-VEGF right, left and center, as you keep hearing from various sources about Paginex and problems about no problems in Paginex, and I keep reading about uniocular patients not to be given, ocular inflammation not to be given, occlusive retinal vasculitis, please, it can occur. So I'm very wary of giving Paginex. I'm not industry driven at any cost. So I'm not going to attend or take part in any of the courses where there's a push by a particular industry, because everybody's got his own views. My views may be totally in isolation, but that's the way I would like to say it in front of all of you, that please don't be driven by somebody, but take your own assessment. That's going to make you a better professional. So it's a neuroretinal degeneration which is not specific to DR, but it's mostly seen in diabetic retinopathy. It's a problem which is rampant in our country. So it's seen in refractory DME. So refractory DME who's already got anti-VEGFs has been treated for center involving DME. We know non-center involving DME, it's possibly you'll do a focal laser. But nobody's going to have a lunch hour session on laser, because laser is not having a father or a grandfather behind it. There's no Genentech and there's no Bayer behind them. So that's the situation, things are different. So there's a disruption of the inner retinal layers. There's reduced perfusion, so the vascular and the neuroretinal degeneration sets in. And this is the way it looks like. You get not only this, but you get hyperreflective foci, which are inflammatory biomarkers. You may get a ORT, outer retinal tubulation. All these are biomarkers. Some are inflammatory biomarkers, but this is also thought drill is thought to be partly post-inflammatory. So that's why the role of steroids comes in, because if it's a refractory DME not responding to anti-VEGFs, there's a definite role of the interleukins, leukeins getting in, and actually the inflammation is not taken care by anti-VEGF. So just because of the vascular instability, which is the anti-VEGF role, you can go beyond anti-VEGF. So now you've got faricimab, which is actually a drug which is going to Ang2 inhibitor plus the anti-VEGF inhibitor. So various combinations and permutations are coming in. So it's basically indicates severe DR, probably more chronic DME, more refractory DME, and you have all these pictures, multiple pictures everybody's seen, so it's nothing new what I'm showing you. It's a serious detachment. The segmentation of the retina is kind of difficult in the inner segments. The ellipsoid band is visible. It seems to be somewhat continuous. There's an epiretinal, so the vitreoretinal interface shows some ERM growing over, or a thickened hyaloid which is growing over, pulling up the retina. So you've got cystic fluid, probably early setting in of ORTs also. Now these cysts are not cystic macular edema. So look carefully. If you've got a hyper reflective boundary or a hyper reflective wall to these cysts, it's probably an outer retinal tubulation, which is a sign of neural degeneration of the retina. So that's not going to be taken care by anti-VEGF. You probably may even worsen the patient, or he's not going to improve. He's going to be very unhappy. You'll have an unhappy patient on your hands. So the question answer as given to me is that what would I do if there's a refractive DME with drill? The way you saw it on the OCT there. So probably I'll still inject. There's thickening of the central subfield, 1000 microns. I might shift to steroids. I might give a dexamethasone implant. And many patients, you tell them carefully, you go talk to the patient. You just can't tell him, I'll give you the injection. So you tell him what it is, show the image, and discuss with the patient. He's ready. And actually, these are they are anti-inflammatory and anti-angiogenic. So they improve the vascular stability, as also the inflammation which is there is kind of gets lower, gets down, and then probably check the vision, morphology, and the central thickness over a period of time. If no response, my approach would be, I'll give a steroid, and then my approach would be, if there's no response, probably discontinue therapy altogether. But I'll try to see the periphery of the retina, also see the metabolic control. Everything goes hand in hand. It's a multifactorial problem which you got to deal with. So they've shown that they had, there have been reports that from one of the pioneering work that showed that drill had some improvement of one line. So take home message, just don't look at the thickness of the center, also look at the morphology of the retina. We don't understand what's the threshold for drill and when to inject, when not to inject. But probably if you feel that patient's got a little thickness is there and there's no atrophy which is set in, you might like to shift to steroids and give steroids. So this is a patient where I gave Ozurdex. You see central outer retinal tubulation, and that's setting in, and there's no segmentation so well seen. There's some interhyaloid remnant, so you can do a dynamic focus on the Triton machine or the Heidelberg and check all these things, and you can see the multiple hyperreflective foci. The hyperreflective foci, as opposed to hard exudates, don't cast a shadow, and they may be smaller, but they coalesce, maybe form a hard exudate, so we don't know. But it's a sign of the degeneration which is there, inflammatory biomarker. Thank you very much.
Thank you, sir. That was really a very clear message that drill is going to happen to the patients who probably would have already received anti-VEGF, because it's not very commonly in treatment naive. So if you have drill and hyperreflective foci and other changes, probably moving to steroids may be a better option. So any questions for Professor Atul? Thank you, sir.
I'll be happy to answer any question. Thiru, you have anything?
Yes.
Can you take a mic? I know your voice will reach us, but it's clearer to everybody.
Yeah, it's getting.
Would you combine giving an anti-VEGF with a steroid in these sort of cases where you have...
Following protocol U,
yes,
I think I'll just give a DEX implant only. Because ranibizumab with DEX implant didn't show better results. Those are a short-term study, 6 months only. But if you follow the drcr.net, it doesn't show any advantage. And actually, I have not seen advantages. So if you get DEX implant, I just give it on its own. That's it. That's my approach.
No, why I ask this question is because when you combine treatment in these sort of cases, you are addressing both the VEGF drive and also the inflammatory component. So,
okay.
Thank you, sir.
But they take care of both, the steroid.
Thank you, sir.
There's been a recent report on fluocinolone also, that it helps over 3 years, but then there are problems of glaucoma and all that. Many of these studies are there now.
The question was whether would you like to combine ranibizumab with Ozurdex, and the answer was very clear that if the patient has not previously responded to anti-VEGF, please move to steroid alone and see what happens. Yes, Nishat, there is a question.
Sir, how will you manage a patient with a proliferative component with drill?
You mean protocol S? In the proliferative DR, there have been reports by Bressler et al. That in protocol S that it's controversial, this particular drcr.net report, that in PDR the anti-VEGFs versus laser, they do better. But if you combine the two, actually go a little off the report, and then you find better results. Because if you only inject anti-VEGFs, the ischemia increases. You may have less vitrectomy, less DME, but they've shown the ischemia goes on increasing. So there are little controversies. And probably in PDR, if you don't have traction close to the macula, you can continue with the anti-VEGFs. But finally, you might have to resort to laser also, which is very definitive, and also maybe surgery. But I suppose there is a role of anti-VEGFs in PDR.
So you will not consider steroids in that or DEX implant in such a patient?
Probably I'll prefer anti-VEGFs there first.
I think if there is a component of proliferative diabetic retinopathy, we all go in for anti-VEGF. One last question, please, ma'am.
Okay, so I would like to ask, in a treatment-naive patient with a lot of intraretinal fluid along with drill and other findings that you discussed, what would be your first choice of treatment, anti-VEGF or DEXA?
Anti-VEGFs.
Okay, thank you.
But if there are hard exudates in the center, more of exudative component with a lot of hard exudates in the center, might go in for a DEX.
And also one thing which Professor already highlighted was the systemic control. Because many of these patients, like what you are describing, would
True.
have some renal involvement, some
True.
metabolic, problems, deranged lipids, and addition of something as simple as lipid lowering helps in tightening the barrier as well.
Definitely.
So that Professor Atul already highlighted.
Thank you.
Well, thank you, sir.